All right, I think we'll go ahead and get started. My name is Austin. I just want to welcome everyone today to the last session for the study club of the DMV. Today's webinar topic will be on soft tissue management around teeth and implants. I'd like to inform you all that you will receive 1 CE credit for today's webinar. You must stay active during the whole session, and at the end of the webinar, you will receive an email from GDIA with a survey link. Once you have submitted the survey, you can expect to receive your CE certificate by email within 14 business days. We will have Q&A session after the lecture. Without further ado, I'd like to introduce our speaker for today's webinar. Dr. Ivanov is a specialist in periodontics with a focus on treatment of periodontal disease, hard and soft tissue augmentation, and dental implantology. He received his bachelor's degree in biological sciences from UC Santa Barbara. He was awarded a DDS degree from the UCLA School of Dentistry and continued his postdoctoral educational and advanced periodontics and implant dentistry residency at the Veterans Hospital of West Los Angeles, UCLA Medical Center. His residency had a great emphasis on medically compromised patients, full mouth rehabilitation patients, interdisciplinary perioprosthodontics, and reconstructive therapy and full arch implant treatment. With that, I would like you to give a warm welcome to Dr. Dmitriy Ivanov.
Hey guys, hey everyone. Thanks for having me. This is, as usual, the online version of a study club is always kind of challenging, talking to a screen, not knowing really who I'm talking to or not seeing the guys, but I'm always excited to share a couple of things that I do in my daily practice, things that I love doing, specifically soft tissue grafting. And I usually love when a session is interactive and you guys asking questions, although maybe you guys can, write. I think there's a way you can write because I can see this chat here on the right side. If you guys have questions as I go through, just shoot it into the chat, and that way I can maybe answer it. I know you guys have a Q&A at the end, but I prefer maybe sharing things as I go along as well. So if you have a question, don't hesitate. Okay. All right. So a little bit about me. If you guys don't know me, I'm a periodontist. This is kind of the pathway that I took here through college to dental school to residency. You guys already introduced me. I do live in Los Angeles and I practice pretty much all over Los Angeles, Orange County, Valley, all around this greater area of Los Angeles and Orange County. If you don't follow me, I do have a Instagram page that is pretty much just clinical Instagram page that I share my cases, share kind of my tips and tricks and things of that nature. If you guys want to check it out, it's perioimplant_LA. I spent a lot of time working on this, so hopefully you guys like it. This is my other page. It's called Perio Amigos. It's just all soft tissue cases between me and my buddy Fadi. So Perio Amigos, if you guys never heard of us, check it out. Soft tissue management is a really broad topic, and a lot of people may think it's, grafting. A lot of people may think it's, something related to implants. It's something related to teeth, but it's a very large topic, and I think I just wanted to broadly describe it in a few cases. So, this is a prime example of soft tissue management from atraumatic extraction, as well as management or maintenance of soft tissue the way it is at the time of extraction with immediate implant placement and temporization. Also site development, and whether it's a Pontic site development or existing edentulous site. So that's a soft tissue management. Soft tissue management at the time of bone grafting procedures, right? Managing the flap, creating adequate incision design, wide enough flap, and also releasing the flap adequately, along with, obviously augmentation at the same time. Aesthetic crown lengthening, that's another big part of my practice, dealing with gummy smile and stuff of that nature. Augmentation procedures, whether it's root coverage, like this is a free gingival graft, which we're going to review a lot today. You guys will learn at least a lot about free gingival grafting in augmentation procedures, but root coverage procedures, that's another part, getting the roots that were exposed covered with autogenous or non-autogenous tissue. And then lastly, developing sites around, implants that may be edentulous sites with deficiencies or defects. So that's just a kind of a broad overview of things that we call soft tissue management. Obviously, there's a lot more, including suturing techniques and whatnot. So, but that's kind of in a nutshell. So when we're looking at this, it's very important to just kind of differentiate the types of tissue we look at, right? And you look at it every single day, and your patients, especially your hygienist, when they look at it, they really have to understand what the difference is between where keratinized tissue is and where mucosa is, right? That defines the amount of total keratinized tissue you have. And the definition of attached gingiva is basically when you probe from the base of the sulcus, from the depth of the sulcus to the mucogingival junction, this is the attached gingiva. And this is kind of an important part of our evaluation of tissues to see how much of this attached tissue we have, not just the keratinized tissue, but how much attached tissue we have. Because it's important in our diagnosis as well as the treatment planning. And if you look at these two cases, this case on the upper left or on the left side, we have obviously recession, but if you put a probe, right, the probe would not go beyond the mucogingival junction, right? The probe would stop just short of the mucogingival junction. What that means is that there's a limited or minimal, as we call it, zone of attached tissue. Minimal meaning that there's at least 1 millimeter, but no greater than 2. And obviously, case on the right, if you put a perio probe down to sulcus, the probe will go beyond the mucogingival junction, and the diagnosis for that would be mucogingival problem. And these two are MGP and MAT or MAG would be the two diagnoses that I would write in my clinical notes. So, and also the progression of obviously the mucogingival problem probably progresses at a much higher rate when you don't have that true attachment, versus a minimal attached tissue. So those are kind of things that we should be looking at the tissue. So as far as what are the factors, back in the days in 1972, we thought that having the adequate amount of zone of KG or keratinized gingiva was absolutely important for maintenance of tissue inflammation free. And these studies by Lang and Low in 1972 showed that when patients had less than 2 millimeters of keratinized gingiva, there was inflammation. And these studies were done way before we even learn about what connective tissue does and how important connective tissue attachment is. But I think in a cross section here, the important thing to understand, let me show you a laser pointer here. If we're looking at the attached gingiva, this is free gingiva, that's the sulcus part, and this is the attached gingiva. I think the attached gingiva, which is the fibers that are running into the root surface right here perpendicular, that's the important part. The connective tissue component of this is what really is important for the maintenance of healthy tissue, because there's a number of many studies that we know from the literature. I can quote you, I think 6 of these studies, they show basically that if you have limited amount of keratinized gingiva, but at least a 1 millimeter of connective tissue that's attached, in the presence of good oral hygiene, you can maintain that inflammation-free and recession-free for many years. And obviously, not all our patients have good oral hygiene, right? Not all of our patients able to maintain with good brushing and stuff like that. So that's when it's important to really differentiate and possibly plan some of these procedures. So like this case on the left, you have very limited zone of keratinized gingiva, but it's very relatively healthy. It doesn't mean that I need to grow more keratinized gingiva because there's very little of it. But if you put a periodontal probe, if the probe does not go beyond the mucogingival junction, that's called minimal attached gingiva. It's healthy, you can maintain that. Now in these cases where obviously you don't really have attached tissue, we do recommend some sort of augmentation procedures. But what about KG around implants? Implants, I think, is a different system, and I highly look at it very differently in terms of augmentation. They're very similar in the sense that they both have biologic width, which is junctional epithelium connective tissue. Implants do not have PDL, right? They have no periodontal ligament. That's a lot less blood supply. It's a big source of blood supply to tissue. There's no inserting fibers that are commonly found around the tooth, right? The perpendicular fibers, we call them Sharpie's fibers. And there's a lot more collagen around the tissue within the implant tissue. And that kind of translates to the vascularization, right? All of the less blood supply, a lot of collagen, so it looks more like a scar. So that type of tissue is a lot less resilient to offenses, if you will, like bacterial infiltration or trauma from surgery or trauma from scalers or anything that can cause inflammation in the tissue. So implants are a lot more fragile in terms of the tissue. So that's why when you're looking at the implant, I think the tissue quality is a lot more important around the implant compared to the tooth, right? Because teeth, I mean, you see teeth last 50 to 100 years with recession and bone loss, but they're still going to be in your mouth. Implants, they tend to be a lot more fragile, if you will. So if we don't have good bone, we don't have good tissue, especially tissue, we may end up in problems with recession, peri-implantitis, and a lot of other things, right? So that's kind of my spiel is about comparing the tooth to implant. Implants tend to be a lot less forgiving than the tooth. So, and the same thing with the studies. Studies do concur that when we have less than 2 millimeters of keratinized attached gingiva, even though you have limited zone of KG, you do have more of a problems like bone loss, higher gingival index. So inflammation is more, plaque is more, bleeding on probing is more, deeper pockets. And if you look at systematic reviews, they agree that having more keratinized gingiva is very, very important for maintenance of implants long term. So KG that's very attached is important. What does it do? It prevents recession, right? The better the tissue around the implant or the tooth, specifically implants, in this case, the more likely that the tissue will not recede, like you see in this case, right? This case is obviously very limited zone of keratinized gingiva. As you can see, there's from here to here, that's all the KG that they have, and the rest of it is unattached mucosa, right? If you put a periodontal probe, or if you push on this tissue is very mobile, right? So obviously there's progression of recession. These implants are about a year old. They just recently got restored about 6 months ago, and the general dentist who restored, they were done by a local oral surgeon. The GP sent this case to me because they saw progression of recession almost as soon as they deliver the crowns. So what else to do? It creates a tight color of tissue surrounding. I always bring an example of a turtleneck to the patients, a really tight tissue that protects anything from going in there. The better the quality of tissue, the better you can brush the tissue, right? It's more comfortable. It decreases the muscle pull, so deepens the vestibule, and ultimately our goal is to maintain stable, non-receded, no bone loss type of tissue around the implant. Another big important factor is tissue thickness. If you guys have seen or heard a zero bone loss concept, the textbook was written by Thomas Linkevichus. He wrote a paper back in the day, way before he actually wrote the book. But he talked about the tissue thickness. They compare different implants placed at different levels relative to the tissue thickness. And we found that when you have at least 3 to 4 millimeters of tissue above the platform of the implant for reestablishing the biologic width, the better the bone maintenance is going to be. So when you're placing an implant, tissue thickness, or you should always place your implant relative to the depth of soft tissue thickness. Obviously, in the aesthetic zone, it's relative to also the gingival zenith, but anywhere else in the mouth, it's always going to be relative to thickness of soft tissue. So you have to place your implant. Majority of cases, you cannot place your implant at the crestal level, basically. Otherwise, you have to be adding tissue and adding grafting above the platform to make the tissue thick. So this is kind of what we want to achieve. We want to have 3 to 4 millimeters of this running room of the tissue from the platform of the implant to the gingival zenith, to the gingival margin for a good soft tissue maintenance of that. So depth equals to thickness. A little bit about evolution of soft tissue. I mean, we've gone through so many different procedures over the years, as you can see. We'll talk a lot about Sullivan and Atkin's paper, which is foundational paper for all soft tissue. But another important notable papers here is Miller, FGG. We're going to talk a little bit about the Langer introduced the connective tissue graft to us. Zucchelli DeSanctis is an envelope flap for multiple recession defects. We tunneling with alloderm was introduced to us back in 2001, and then Zade introduced Vista, which technique that I'm going to talk a lot about today as well. Chow, which is the technique called pinhole. I underline it because it's the only technique that have to be taught by paying, for the course and writing citing like an NDA agreement not to disclose everything, and you have to basically use the patented instruments only to practice it. So kind of very monopolized procedure. And Scolian technique, laterally closed tunnel, I'm going to share that technique with you today as well. Okay, so Sullivan and Atkins again, it's a foundational procedure, and I want to spend a good amount of time talking to you today about this because it's an important procedure. It was introduced to us by Bjorn, and Sullivan and Atkins wrote a paper The Way We Know It Today. Highly recommend reading it. If you guys need any papers that I'm mentioning here, I'm happy to share any papers with you as well. So it's an epithelial graft, right? It's the surface of the palate. It's the best way to gain keratinized tissue, whether it's around the tooth or around the implant. It's not as aesthetic as a connective tissue grafting. You'll see the differences. It just looks different in most cases. And the majority of times we don't use it for root coverage, right? Especially in the aesthetic zone. Key is to immobilize it. And it could be the most uncomfortable procedure, although the way I protect my palate, I'll share my views. Most patients don't complain about the discomfort about the pharyngeal grafting. So this is the decision making that goes through my head every single day. I see these patients, and by the way, all the cases I'm sharing, these are all my cases. You guys are welcome. If you want to take a picture, I'm okay with that. You can find all of these cases on Instagram as well. But these are the kind of the cases. These are the thoughts that go through my head every single morning. Like, which route do you take, CTG or FGG, right? And it really based on these few pointers: your clinical experience, the goal of the therapy, whether it's root coverage versus just an augmentation, right? Not all cases require coverage, right? Some cases you can get coverage, which we'll review some of the classifications. Do we have a freedom pool that we need to manage at the same time? What is the vestibular depth like? And what is the location? Is it aesthetic zone? Is it a non-aesthetic zone? Is there, location for different muscle planes? Lower mandible versus upper maxilla, a very, very different approach that you have to take, right? There's for example, lower anteriors have these freedoms that come up so high onto some of the teeth. Sometimes we have very shallow vestibule due to mentalis muscle high attachment. And the approach that we have to take to these cases is very different between mandible and maxilla a lot of times. Well, let's see. So let's review steps of a free gingival graft, since I want you guys to really understand what free gingival graft is and how it's done. So this was a 65-year-old female, generalized recession. She has a pretty stable dentition in this area, some staining she drinks a lot of wine, and she wanted to maintain these teeth. She's been seeing some progression over the years. She's not ready to lose these teeth by any means because they're stable, but we want to stabilize tissue to hopefully so the gums or tissue does not recede further. If we look at it, this picture is a little deceiving because it's taken from a little bit over the top of the teeth. But if you look at it approximately, there's a lot of attachment losses. You can see in a lot of cases when we're going to review Miller classification, which is this case would be called a Miller 4 classification because we have severe and approximal bone loss. And in Miller 4 defects, generally we cannot achieve 100% root coverage, nor any root coverage per se. So in the cases where my goal is not root coverage, I want to go for an augmentation procedure. An augmentation procedure is usually what it means. You are augmenting keratinized gingiva. You're trying to gain better quality tissue. You may or may not get root coverage with this procedure, but what you're going to gain is a lot more attached keratinized thick tissue. So that tissue will maintain that gingival margin in that position indefinitely until she's 100 years old, hopefully, right? So that's kind of my decision making. In the mandible, it's very frequent that I do free gingival grafts for these type of cases because, like I said, connective tissue graft is mostly used for root coverage procedures, as you will see later, but free gingival is used for augmentation just to gain keratinized tissue. Yeah, feel free to write any questions in the chat box. I can see you guys writing or asking questions. So if you have any questions right at the bottom here, just send me a quick text or a message. I'll be able to reply to you right away. So the first step in a pharyngeal graft is a split thickness incision, right? It's creating a periosteal bed. So this is where the place where graft will be laying or secured, right? It is a split thickness incision. As you can see on the picture on the right, I took the flap that I created, a split thickness flap, which you're looking at as periosteum, and I secured it apically with these sutures to periosteum. So that allows you to deepen the vestibule and basically stabilize that tissue apically. We call them base dice. This step two is harvesting your donor, right? Or donor site. The donor site is an epithelial tissue from the palate. I create an outline based on the size of my graft that I need. And this step of a harvest, usually you want to be no thicker than 1.5 millimeters. If you look at this paper by Solon and Atkins, he recommends taking tissue no more than 1.5 millimeters, because the thicker the tissue, the uglier it looks. And although it is more stable, it doesn't shrink as much, but it doesn't look that good. And plus, it's more painful to the patient. If you take tissue too thin, it shrinks too much when it heals. Although it does blend a lot better. So thinner grafts, they look better, they blend in better, but they shrink tremendously. Sometimes if you took, let's say, 10 millimeter width graft, you might end up with 5 or less millimeters, so 50% shrinkage. So you want to be between 1.3 to 1.5. That's kind of the ideal thickness. Step number 2, or this would be step number 3, I guess, because we already harvested the graft, is to secure the graft into place. And here, usually what we do by securing the graft, what I mean is, I start with the coronal sutures. So this procedure basically allows you to stabilize graft in 3 dimensions. The blue sutures is the first sutures I do, because I just interrupted sutures through the remaining attached tissue. And then these crossing mattress sutures that I do secondary are the periosteal sutures that are allowing to compress the graft into the periosteal bed. These just variations of different types and ways to secure. I mean, virtually it's all the same. I mean, as you can see, there's sometimes crossing mattress suture, sometimes they're parallel mattress suture. Depending on the situation or the area or axis, I can vary these. The goal is to really just stabilize the graft, so there is no dead space in between the graft and the bed, right? You want to adapt it as much as possible, as well as possible, to the periosteal bed, so it's in intimate contact with the bed. It's very hard to make the grafts very pretty looking. It's always kind of looks messy almost, because there's so many sutures going every direction, but it's a very functional graft. This is not I even call it to the patients when I'm talking, there's a pretty graft and not so pretty graft. So I tell the patient, this is not so pretty graft, but it's extremely functional, right? Next step is to protect your palate. Once the graft is secured, we want to protect the palate. There's many ways to do that. I generally prefer using periacryl. So periacryl is like a gum super glue. You can either directly pack it into the defect that you harvested from, or you can place a collar tape and do the same thing with the layer of periacryl. Or the third way I do it, let's say if it's a heavy bleeder or a very large harvest, I generally would put the collar tape. I would suture the collar tape using chromic gut sutures, just to hold it in place, just crisscross, and I would place periacryl right over the top of that area, just to protect it even further. So like up to 3 layers of protection. So that's my favorite way. You can also use a stent, palatal stent, which is a simple suck down. If you guys are able to make the simple suck down, it's beautiful. It works really, really well as well. Okay. And then evaluate your results. So as you can see, there's a difference between the existing tissue and the graft. It stands out. You could tell that this looks different in terms of the kind of a blending, and that's very common with pharyngeal grafts. Hence why it's not the most aesthetic graft if you are doing it in the aesthetic zone, right? In the aesthetic zone, obviously, we don't want to do this, and I think connective tissue grafts, as I'll show you, work a lot better. So there's many reasons why we do the pharyngeal grafting procedures. Root coverage, right? We gaining an attachment, as we already showed you guys how to gain attachment with a free gingival graft. Gaining tissue thickness to improve thickness of tissue, more connective tissue, whether it's around tooth or implant. If you have cold sensitivity right around the tooth, it improves the thermal sensitivity, makes the patient looks better, right? If you have very long roots, patient likes to have shorter roots. Pre-prosthetic root coverage, if you're planning maybe veneers, some of the teeth might be longer or shorter. You want to either crown lengthen them or root cover them, and improve periodontal maintenance or decrease marginal discrepancy. So those kind of defects are very hard to maintain sometimes because they're on a different level as the rest of the tissue, right? One recession on one level and then the rest of the gingiva is at the other level. So it's harder to brush sometimes. By bringing everything to the same level, patient's able to maintain better. These are very common implant-related procedures that we do. Post-GBR is very common reason why we do a free gingival graft, especially in a very resorbed areas where a large graft was done and the tissue was so coronally positioned to get primary closure that we need to reestablish that. As you can see, this is after GBR, and this is after free gingival graft was done to reestablish it. Before GBR, in some cases, that helps to maybe improve tissue quality, post-implant placement, and pre-implant placement. So depending on on the situation, I'll show you a few cases. So again, the same case I showed you before, implants placed less than a year ago. You can see the dark hue showing through whether it's an abutment or an implant. There is no inflammation around the implants. They're healthy. They just have lost some bone on the inside, and the tissue is too thin. So ultimately, if you let these implants, leave these implants for few years in function, they may be more recession. There may be more deepening of the pockets, inflammation translating to periimplantitis. So we don't want to do that. We want to improve the quality of this tissue. So we're going to add a nice free gingival graft, keratinized graft to augment this tissue. So the bed was prepared the same way. This is a split thickness incision. We want to expose periosteum that's nice and attached. We're going to harvest the graft. It's going to be nice within the parameters, maybe 1.5 to 1.3 millimeter in thickness. And we're going to sometimes you can take a thicker graft. I mean, these posterior non-aesthetic areas, especially implants, you could take a 2 millimeter free gingival graft if you want as well. So it's no real trouble if you took it a little bit too thick. Too thin grafts, they tend to shrink a lot more. And the next step is to secure the graft. Again, I start with the coronal sutures. I kind of stretch the graft with my sutures, stabilize it, and then I do my crisscrossing or parallel mattress sutures to compress the graft into bed. Take you forward 2 weeks, as you can see, this is a suture removal appointment. The entire graft is already vascularized. It's taken. It's a very quick process. So it's not like waiting for a bone to grow. It's the process of free gingival graft healing is extremely quick. At 1 week, you already cannot do much to the graft. You cannot tear it off. It's completely vascularized and attached. So this is 2 weeks, and I think we have a little bit longer follow-up here, 4 months. As you can see, great things: increased zone of keratinized tissue, tissue thickness have improved, right? We also deepen the vestibule. If you could see, the vestibule was all the way up here somewhere. That was the kind of a mucogingival junction. This is all an unattached mucosa. Now the new depth of the vestibule is at the bottom here. What it allows us to do is now all the muscle tension from this muscle right here, muscle pull, is only accumulated here. None of the tissue is being bothered when the patient talks, speaks, or brushes, right? So it's those are kind of the main improvements. And obviously, you cannot see the implant because the tissue have increased in thickness. And ultimately, you can get some coverage of the implant metal just because the graft was done. It was unintentional. And in fact, some of this tissue will creep up, continue to creep up in the next few months to get even more coverage of the implant abutment. That's the beauty of autogenous tissue. Another case, kind of a broad case, these cases are very challenging sometimes to treatment plan because you want to get some coverage of these roots, but at the same time, you really have very poor quality thin tissue that's like toilet paper thin. So a lot of cases like this, we either stage it. This is an older female. She didn't really get bothered by the length of the teeth so much. She just saw the progression of recession in the last few years just became very quick. So we decided to augment this area, although I think root coverage would be possible partially, and especially in some of this lower left areas. And we decided to first augment the tissue to create good zone of keratinized gingiva, maybe get some root coverage, and in the subsequent step to offer her some root coverage procedure. So this was a 2 pieces free gingival graft. As you can see, relatively large, both pallets were taken, left side and the right side, and the bed preparation, the apical positioning flap of the flap, and then as you can see, I actually secured the flap to deepen the vestibule. If you look at the vestibule and the freedom that were in position here, we wanted to push everything down. So I tried to apically position tissue, secure that to the periosteum to deepen it, and then harvested nice long, 2 long pieces of refrigingial graft. In cases like this, I generally do one side. I finish this one side because I want my graft in place, and then I do the second side right away after that to do the stabilization. And this is a good example of placing periacral. This is just basically gum super glue packed into the defects to create this super clot that stays there for about 2 to 3 weeks. She kept it in for about 3 weeks. She had zero pain almost. I think I have a video of her giving a testimony that she took like 1 Tylenol over the whole time. It's just, unreal sometimes looking at these cases, but it could be relatively painless procedure if it's done right. The palate is protected all right. And this is how we look at 4 weeks, right? If we're looking at or evaluating the results here, as you can see, great canine keratinized gingiva is beautiful. Overall, beautiful tissue, beautiful thickness of tissue. We got some root coverage indeed. And as I mentioned before, the root coverage will continue, will creep up a little bit more and more over time. So that's how we manage. And this is a 4-week follow-up of her palate. Nice healing. I mentioned that FGG is not used commonly for root coverage, but P.B. Miller, he described the technique basically using a freegingival graft for root coverage. You just have to modify. Usually it's mostly thickness. You've got to, extend the graft a little bit more laterally to get a lot of, blood supply to the graft. And the graft has to be moderately thick. Usually it's at least 2 millimeters in thick if you want to get some root coverage. So this is a great example, lower anterior tooth. Very frequently I see it after orthodontics. There's one single tooth that develops recession. So we treat it virtually the same. We prepare the bed. The design here I like to use, if it's a single tooth, it's like a triangular or trapezoidal in shape bed. The graft is taken nice and thick, and you can't really appreciate it on this picture, but the graft is at least 2 millimeters in thickness. So it's very robust, very thick. The thicker the graft, more likely it's going to survive on the periosteum, on the naked root surface, right? Because root surface has no blood supply. The rest of the procedure is the same. You have to stabilize the graft, you have to secure the graft. And let's look at the follow-up. So this is 1 week and 1 month follow-up. As you can see, we're able to get beautiful root coverage. There is no probing depths. If you put a periodontal probe right there, the probing is going to be 1 to 2 millimeters usually. So the way the free gingival or connective tissue graft gets attached to the root is via long junctional epithelium. The same way periodontal pocket could be decreased from 6 to 2, right, by just doing some good root planing. It's the same concept. Long junctional epithelium forms, and it becomes very, very stable for a long time if you keep it inflammation free. So that's before, and that's 4 weeks after, right? You can appreciate the thickness, you can appreciate the vestibular depth, and you can appreciate obviously the root coverage. And this procedure eliminates all the freedom, right? If you have a freedom that's so high up, heavy freedom pull that's so high up, there's no better procedure than a freegingival graft in this case, in these kind of cases. Okay. Posterior, when you're dealing with hard and soft tissue augmentation, or hard, generally if you're dealing with a deficiency that requires bone augmentation, I generally, my rule of thumb is to always recommend soft tissue grafting after. Some cases we don't need to do that, and that's great. Patient wins, I win as well, but majority of cases we do require some sort of an augmentation. I'll show you this this one case. And the reason why is because every time we're doing an augmentation procedure, we advance the flaps so coronally and sometimes that you obliterate the non-existent keratinized tissue from the beginning. You already had limited kg because you were missing a tooth for a while. Now you advance the flap and decrease the width of that keratinized tissue even further. So that's why I highly recommend at least talking to the patient so it's not a surprise to them when you tell them, hey, Mrs. Jones, you need a gingival graft here, and it's been like, you're already ready to restore your implants. So this case needed a large GBR. They're pretty good defect. It's a decent defect in terms of containment, so kind of easy defect to grow bone. So we placed our implants, used a sausage, kind of a sausage and sandwich technique here to do the graft. I love this membrane. This is a Salvin Renovix Plus membrane. If you guys use that, it's a great membrane for sausage augmentation with mysocured tax. I get it from Salvin. And the autogenous shavings were also scraped from the local area. But look at the keratinized gingiva where we ended up. If you remember where we started, let me show you the pre-op here. Let me show you the pre-op real quick. So we had a kg that was relatively okay here. I mean, not ample amount, but it was decent. It was right up to this gingival margin. But look where we ended up at the time when we came to 6 months post-operatively. So remember, kg was here. No keratinized gingiva became all the way up to the top. And that's very frequent finding with any time you're advancing the flap. But we opened up the flap. It's obviously beautiful bone gain. You cannot see the implants. They're somewhere inside this massive amount of bone. It's a huge tumor that we grew. We took out all the tax that we needed. We exposed the implants. We put the healing abutments, created a nice profile. Remember, place implants at the right depth, right? We don't want to place implant too shallow or at the crestal level because imagine if I placed my implants at the bone level right here, instead of being subcrestally, at the end, I'll be very, very shallow because my tissue is so thin, right? So you want to have the implants at the right depth from the beginning to make sure that you're considering the depth of tissue thickness over the platform of the implant. So this is a good example. We exposed the implants. We waited for the healing. I tried to push some of the tissue to the buccal, right? We didn't have a lot on the lingual to give out, but I pushed as much as I could on this tooth, which we gained a little bit. But this tooth, we had almost no keratinized gingiva. This is all unattached mucosa. So we decided to augment this tissue. Patient was already aware that he's going to be getting a soft tissue graft at the end. So split thickness flap. Yeah, be very mindful of this area when you're doing a split thickness because there's a mental foramen here somewhere. Make sure you know exactly where it is and how far it is. So we want to be very careful. We want to get as close as possible to bone without touching the bone, right? This is all periosteum that's exposed. We took this was a little bit thicker graft, probably 2 millimeters or so, a little bit thicker, but I wanted to augment the contour of this tissue as well. So secure the graft to the bed. This is kind of an occlusal view, just showing you the width. I wanted to kind of recreate the existing ridge width that patient used to have maybe a while ago. And this is how we healed. I think this is several weeks after. I would say this is 4 to 6 weeks after the graft was done. A beautiful result, beautiful tissue thickness, great contour augmentation. Does it look beautiful in terms of like aesthetics? Maybe not, right? It looks different. It looks like something was done, but it's extremely functional. It's extremely resilient to any kind of issues with the inflammation and obviously brushing and maintenance. And look at the vestibular depth, right? The graft reestablished our depth of the vestibule here that we obliterated during our GBR procedure. So this is an example of before and after. You can see nice little plump area. As you can see, this was a lingual tori, by the way. This is not his ridge. This was a lingual tori. The ridge was right here, which was very deficient or non-existent. This is where the implant ended up, right in this spot after we augmented it. So let's talk. This was the basics of a pharyngeal graft. Pharyngeal graft is the foundation. I think if you are planning to or do already procedures in soft tissue, there's no better procedure to master first before doing anything advanced like root coverage than a pharyngeal graft. And it's very kind of, I don't want to say it's a dummy proof, or what do you call it? It's not foolproof procedure, but if you follow protocol, majority of times you're going to succeed very well. Root coverage procedures is another big part of my practice, and we get patients from all kinds of ways. Like this case, hey doc, can I just get some whitening, please? And you guys see this a lot too, right? Patient comes in, it's completely oblivious that they have like a 15-millimeter root recession. So the root recession is very diverse, and the reason why it's diverse because the etiology is generally very diverse as well. We have a variety of recessions, causes of recession. A lot of it has to do maybe with brushing techniques. A lot of it, like some of these abrasion cases, right? The first one you see. A lot of it has to do with fractions in some sort of a parafunction habits, right? Whether it's a malocclusion, whether it's patient habits, and things like that. Complications like these two bottom cases, bottom left and bottom right here, those are complications from an oral surgeon after a three-piece, basically orthognathic surgery. They did a three-piece right in between the roots of they usually do that cut or split between the canine and the lateral, and not infrequently this ends up as a recession on one or both teeth, especially if there's some attachment loss. So the variety of things, they come in all shapes and sizes, but you gotta really look into what's causing it and hopefully correct the cause of the problem, not just do the treatment only. And what goes through your head is a new patient, how bad is it? What is the etiology? How hard is it to reach there? Is the depth of the vestibule shallow or deep? And do we have a lot of keratinized gingiva or not? And those will give you different techniques. A Miller classification, we'll go over this. Miller classification is a way to kind of classify different recession defects based on their depth of recession, whether it's up to or beyond mucogingival junction, and based on the interproximal bone loss or tissue loss. So Miller 1 is when you have a perfect, most ideal defects, where you got recession that does not extend beyond the mucogingival junction, and it does not have any attachment loss. So it's a healthy interproximal bone, healthy interproximal tissue. Miller 2, it's the same thing, except the recession is now going beyond the mucogingival junction, or up to or beyond mucogingival junction, but we still have good, healthy interproximal tissue. So generally, Miller 1 and 2 are the defects that you want to treat because they are predictable, the most predictable, and they are most predictable in terms of complete root coverage, right? You can hopefully achieve 100% root coverage. What goes through your head again when you get to these more severe cases? Well, maybe some of you hopefully will refer these cases to somebody like me or your local friend periodontist, because these are more challenging cases. Miller 3 is when you have interproximal bone or tissue loss. And Miller 4 is obviously severe bone loss interproximal, and we switched too soon. Severe interproximal bone loss or tissue loss, as you can see these. Miller 3, you can anticipate some root coverage, partial root coverage, and in the Miller 4 defect, you cannot anticipate any root coverage at all whatsoever, right? So don't promise patient that you're gonna, patient comes in, oh, I have holes in my teeth, what can I do? There's lots of things that cause gingival recession. I'm not going to go over each of them, but you do have to sort of differentiate what causes gingival recession, whether it's trauma from, brushing, piercings, whether it's an orthodontic trauma and things of that nature. But we do have to look for those things. This is just a small list of things that we utilize to do root coverage procedures. This is like golf irons in your golf bag. You could use any of them interchangeably to drive your 100 yards, whether it's a putting, probably not a putter, but whether it's a wedge or it's an iron, you can probably hit it softer or harder to get to 100 yards. So same thing with certain procedures. You can utilize them interchangeably. And sometimes you utilize both within the same procedure. I'll show you how I use it. So tunnel is conventional tunnel parallel technique. Vista, which we're going to talk a lot about today. LCT, which is laterally closed tunnel, the newer technique, very simple modification to a tunnel. Zucchelli approach, pedicles, autogenous grafts, which is connective tissue, allografts, which is a human donor tissue, and then xenografts. It's usually made from some sort of an animal origin, a replacement for connective tissue. Vista, also known as a vestibular incision subperiosteal tunneling approach. The procedure is a full thickness tunnel done through the incision right here, either at the midline or a location that's closest to the area you're treating. First step is basically to create, and let's look at the every step of this procedure in a case form, right? So if we're looking at this particular case, this is the same patient who has lower anteriors that have been progressing over time. He has a very limited zone of keratinized gingiva, almost no vestibule here, it's just all mucosa. And obviously severe recession, 0 millimeters of attached gingiva, shallow vestibule. First step in these procedures is to clean the roots, right? It's just SRP, root planing. You just clean it. You can recontour the roots if they're very, largely protrusive, or if they're very ovate, kind of convex. You want to decrease the convexity, flatten it a little bit, and to bring it into the housing, because tissue does not like growing over convex surfaces. Chemically, you could use EDTA or Pref gel if you like. It doesn't really improve the outcome of the procedure, but it does clean the root, maybe makes you feel better. If you feel like you want to follow the true protocol that Dr. Zade recommends in his paper, we have plenty of papers showing that there is no difference between using any kind of chemical or not. So step number 2 is to create a vestibular tunnel, right? Everything at this point is done through that vestibular tunnel. And this is a full thickness tunnel. So you go straight to bone, then you create a tunnel from the vestibule, going mesially, going distally to beyond the recession areas. Some of the sources that will be the step number 3 is to take some sort of biomaterial, whether it's a pallet, connective tissue graft. It could be a subepithelial graft harvest, right? I'll show you guys what that means. It could be a deepithelialized free gingival graft, or it could be a tuberosity connective tissue graft. Those are autogenous tissue. And the substitutes could be a soft tissue allografts like an alloderm. I use Salvin allograft, which is phenomenal. It's similar to Straumann allograft, but there's so many on the market as well. I'll share my views in a little bit when we talk about it. And xenografts, I don't use a ton of xenografts. Just haven't really gotten around using it routinely, but I've used Ossex Plus and I used the Fiber Guide before quite a few times. Just to me, nothing really substitutes the autogenous tissue. It's very simple to me to use autogenous tissue because of the predictability. But Dr. Gene Kim, he loves using Fiber Guide. He has a number of amazing cases. If you guys want to learn more, I'm sure he'll be happy to share his experience with Geislich Fiber Guide. Autogenous is still the gold standard, right? Nothing. We can read many papers. Chambron et Takis. There's nothing comes close. It's the best outcome for mean and complete root coverage using autogenous tissue. The step number 3 is to take that tissue. So this slide just basically shows the one way to do this. This is a single incision. You create a split between the connective tissue and the epithelium, and you take that epithelium basically out of the way. You push it out of the way with a single incision, and you take the middle, the connective tissue part, which is shown right here in this last slide, or in this last picture. As far as the 4th step is to basically take this connective tissue that you just harvested from this step and place that internally into the tissue, right? The graft goes inside up against the roots, and the graft and the flap gets advanced together with coronally repositioned tissue or slings to hold that up. To hold the graft and the flap together. This is one way to coronally position it. The composite buttons, I don't do too many of them anymore. I used to do a ton, but it's just pain in the butt removing them later, and patient has this button kind of rubs against the cheek. It's not the most comfortable. So most of my procedures I do today is with just a conventional sling periosteal, a Pat Allen sling as we call it, because he's the one uses or started using this particular procedure technique first. And again, this is just shows the way the subepithelial, if you guys ever heard of subepithelial connective tissue graft, this is the way it's taken. It's taken from the inside of the palate, right? You're taking a subepithelial version of it. Generally, this type of graft can be thicker, but a lot of times it brings fat with it and glandular tissue, which is not always the best quality, right? If you have a lot of fat. The alternative to harvesting subepithelial graft or any palate graft is tuberosity. Tuberosity is phenomenal tissue because it does not have any fat. It's just pure collagen. And it tends to, if you take thinner version of that, it tends to grow over time and actually create more volume of tissue. If you need more volume, nothing beats the tuberosity grafts. And this is a suture removal appointment. Generally, I wait about 30 weeks to take out the stitches. As you can see, it increased in the depth of the vestibule because connective tissue inside is now firmly attached. There's some gain in keratinized tissue. Complete root coverage was achieved, and same thing on the lower right side. As you can see, the phenomenal result of reestablishing the vestibule and increasing zone of keratinized gingiva. This is a 3-month follow-up. Just showing very nicely maintained tissue, very nicely maintained root coverage. This is before and after. Okay, and this is again the same exact comparison before and after. Great root coverage, good vestibular depth, good gain in keratinized gingiva, and relatively stable patient. I think he came in for a maintenance at that visit. After 2 months, majority of patients that don't touch the teeth during the healing period will accumulate plaque required if it's not clean. So another great case. What are the challenges? So the big challenge is how far out this root is, right? Patient had orthodontics and he has some obviously parafunction. If you could see a lot of wear on his incisal edges here. This big gentleman with a lot of heavy occlusion. That's what's going to happen. Over time, if you hit this root over and over and over, so if you hit this root over and over in your protrusion or lateral intrusion, what's going to happen is the bone starts to dehiss on the outside. The bone was, first of all, very thin already, right? Because it's so buccally placed. Number two, when you have parafunction, that a bone starts to dehiss, and over time, in combination with this frenum pull, you develop recession, right? So that's usually recession is not caused by one single thing. It's like a syndrome that has multiple different things that have to happen to really, push this overboard and continue to progress. But this case was managed very similarly, was managed with Vista. I created an vestibular incision here. I tunneled mesially, I tunneled distally in this area. The papillas were undermined from the inside. So it's still a tunnel, meaning that the papillas are fully intact, but the tissue can mobilize, right? It moves up or down, it moves coronally. And very passively, this is not like something you have to pull on to advance. As you can see, we traveled pretty far from here to here, but this is very passive, meaning that if you take the tissue and you put it there, it shouldn't have a lot of resistance pulling it. The sutures here, there's actually 3 slings, 1, 2, and 3 slings. They're biting through the graft, they're biting through the flap, it goes around, you bite through the flap, through the graft, goes around and tie. So again, this is called interrupted sling suture. And there's a couple of stabilizing suture like this one and this one. It bites the graft right here and right here, just holding it, nice and stable in 3 dimension. And I think this is 4-month follow-up. Just forwarded to 4-month follow-up. As you can see, tremendous amount of gain in tissue thickness, amazing root coverage, and as you can see, the vestibular depth. You see where the frenum is now compared to where the frenum used to be. It got repositioned as well. So it's a great way to push the frenum far away from where your tissue gingival zenith is, right? So it's kind of like a frenectomy by doing a connective tissue graft. The beauty of it is this is all new keratinized tissue. That's, if you see the outline, this is probably the outline of the previous recession. This is where the gingival margin used to be. And this is all new gum, new keratinized tissue that was achieved with just using that autogenous tissue. What about abfractions? I get this question very frequently. Abfractions are great, great effects for root coverage. Actually, I love grafting abfractions, and the deeper the abfraction, there's different classifications for abfractions, but the deeper the abfraction like this one, actually, the better quality tissue you're going to get overlying. I mean, there's obviously some abfractions that do require restoration prior to this, and sometimes you require after, but majority of these kind of abfractions, they can just be treated with connective tissue graft. So they are very, very good. Another way to harvest connective tissue, good quality connective tissue, is to take a deepithelialized free gingival graft. So you take a FGG, just like we saw in the first part of the lecture, and remove the epithelial layer. We take a blade and just remove the very top layer of like 0.005 millimeters from the top, just exposing all of that connective tissue. And that's what you see in this left picture. This was a distal incision that was done. The tunnel was created mesodistally, and we deepithelialized everything in terms of removing epithelium, leaving connective tissue only. The beauty of it is you could take longer, bigger grafts than you could with subepithelial harvest, right? Subepithelial going with a single incision. The graft is placed, it's sutured together around with the sling sutures, as you can see in this picture. These are sling, sling, sling. There's a double sling here, double sling there. This incision is closed. And then we can fast forward again 6 weeks. 6 weeks, this is a great outcome in terms of what we were trying to achieve is deep in the vestibule, right? We increased zone of keratinized gingiva. We got thicker, I mean, tremendously thicker tissue and a beautiful coverage of the roots. As you can see, portion of the fraction that's above the CJ, that's impossible to cover. You can't get higher than CJ, but where the CJ was genetically, that's where the tissue ended up there. And there's no need to put any composites on the roots like, in this kind of cases. There's two ways to create deepithelialized FGG. You can do it intraorally with the burr, or you can do it extraorally with the blade. So intraorally is like this. You create an outline, you take a diamond burr, you just deepithelialize, remove the top layer of epithelium with a high speed. And then you can harvest this piece right here just by removing it the way you would remove a free gingival graft, right? It's just now it's the deepithelialized version. And then you can use that deepithelialized version in your connective tissue graft, just like this of it showing. Majority of my cases that I do today, I would say 99, maybe 95% of my cases is deepithelialized grafts because they a lot less pain. They grow in thickness tremendously well. And they are quick. I mean, for me to harvest free gingival graft like this, it probably would take me, I don't know, 50 seconds, maybe a minute at the most. Deepithelialization takes maybe another minute or so, and then you're already putting the graft in within less than 2 minutes. So that's kind of my take on this. But as far as the extraoral, you have to harvest the free gingival graft. You use a brand new blade to remove the epithelium that way as well. So those are the two ways. Sometimes we got to graft multiple teeth, obviously. As you can see, there's multiple teeth across the arch. There's a pontic space that's a little bit challenging. There's also crown margins that are exposed. So those are not very easy to usually crown margins are the hardest things to treat and cover, especially when you have a Miller 3-like defects. As you can see, there's an proximal tissue loss. There's at the pontic site, as well as the rest of the tissue. But we would treat this exactly the same. We would create a vestibular incision. I made, I think, 2 or 3 vestibular incisions here. I think there's one right here. There's one at the midline, and there's one a little bit laterally. It doesn't matter how many you create. You could, whatever allows you to tunnel distally, whatever allows you to release tissue, you could put 2 more if you wanted to, if that helps you, right? Because you're trying to tunnel through that little incision coronally and distally. if you're covering this canine, if you're covering this canine, you do have to go at least the one tooth over to be able to release this tissue. Same thing on this side, you have to go beyond this premolar right here to release this tissue to be able to mobilize it really well, right? So here we took a deepithelialized graft. Again, we inserted it through the vista incision, and we coronally repositioned with the slings the same way. Fast forward it to 3 weeks. 3-week follow-up, patient came in. As you can see, we removed the sutures. What we're seeing here is the graft that's slightly exposed, that was left exposed, intentionally left exposed, is now basically regenerating connective tissue. It's regenerating connective tissue as well, right here. This is all new tissue that's growing, right? Which is beautiful. Beautiful root coverage. So some patients, in my practice, I don't see a lot of patients that refuse palate graft, but there are patients that either don't want to do the graft. In some cases, you can actually avoid using the palate as well. So there are options. We could use acellular dermal matrix. ADM is a substitute for connective tissue of human origin. There is some evidence that show that alloderm or allografts can show gain in attachment and increase in kg. I honestly have never seen that in my cases, but what other literature does show is that the connective tissue shrinkage between connective tissue and the dermal matrix is dramatic. I mean, alloderm and other, they tend to shrink a lot. So 71% shrinkage this way showed in this paper compared to CTG, almost no shrinkage. And then this is a great study. Harris compared alloderm root coverage versus a connective tissue graft root coverage, showing that the short-term results, like 3 months, as you could see, connective tissue short-term 97% root coverage, alloderm 93% root coverage. So pretty similar, right? In high 90s, mid 90s. In the long term, though, if you're looking at a few years have passed, as you can see, the connective tissue is still 97%. We're still covered. Roots have not receded since. But on the long term, on an allograft, we tend to see a rebound effect, right? We see a lot more shrinkage, a lot more decrease in root coverage and thinness. I mean, you see how thin the allograft gets. There are many of them on the market. People ask me which one do you prefer, which one do you like. I generally, right now, if I do use an allograft, I either use Salvin allograft, which Strawman and Salvin, it's the same company allograft. It comes from a LifeNet Dermis. They just resell it under their own, under their own brand, basically, but they're retailers. I used to use Perioderm, which I was not really happy with either. I mean, it's not too thick, it's not too thin, it's just whatever. And then Alloderm, I never liked it. It's always been too thin for me. So let's just show a case. This patient was treated with an allograft, done a vista approach, very similar technique. If your allograft comes out very thin, what you can do is you can double layer it, right, to increase the thickness of it. If the allograft, that you open the package is really thin, just double layer it. You can actually cut it in half and just put it on top of each other, and that will give you a nice thickness. And the thicker the graft, more likely it's going to retain better. So this was done as a sling sutures that were using composite buttons because the defects were maybe at that time, and this was a very old case of mine. I don't love using these composite buttons. Like I said, you have to drill them out later. You have to polish teeth, so it takes a lot of time at the post-op visit. This is a 4-month follow-up, and this case actually, even after a couple of years, has been actually very stable. So, but again, I had to double up the thickness of that graft to make sure that it's the right thickness. A very cool technique called laterally closed tunnel. It's a not very no-brainer kind of procedure. It's basically a modification of a conventional tunnel. You could also modify by using Vista approach, or you could use it just like a tunnel. So what it allows us to do is it allows us to create a tunnel just the way we create a tunnel for whatever, Pat Allen, they used to teach a tunneling approach. So we create a tunnel through the sulcus, we introduce the graft through the sulcus in this manner, and we secure it mesially and distally. And then the recession, it's usually which is narrow and long or deep. We are able to simply laterally close it. So we're closing the tunnel from the base of the defect coronally. Okay. So this is a perfect example of a laterally closed tunnel. We clean the roots really thoroughly. We harvested the tissue. We place the tissue into that tunnel. And now what we're going to do is we're just going to zip up that recession from the apical to coronal in terms of laterally closing it. So that's an example of that. And then this is him on a Sunday afternoon sending me a picture of how excited everything looks. It looks really great. That's the tooth that we treated. And this is a picture. I think this was 2-month follow-up. It's also from his camera. Yeah, I don't think I got the actual clinical photo, but this is him, super excited, great result. You know, he's gonna maintain this tooth hopefully for a lot longer. Sometimes you can modify the laterally closed tunnel by using Vista. So like this case, I treated with conventional Vista approach for these teeth in the mandible area, and then tooth number 26 was treated with a laterally closed tunnel. But access and tunneling was all done through the Vista approach, right? This was a access right here. We tunneled mesially, we tunneled distally this way, coronally, and then the graft was placed across this entire area. And then this was closed like a laterally closed tunnel, as you can see, this closure here, right? And everything else was closed using coronally repositioned slim suture. And let's forward you 4 weeks. As you can see, beautiful healing. This is the new tissue that's forming and growing. That's a keratinized tissue. That's because we left a little bit of graft exposed. It's completely normal to leave a little bit of the graft exposed. You can leave it up to 1 millimeter. The graft that's exposed usually keratinizes and becomes newer, better tissue. Okay, and that's how we finish this case. Okay, we just go quickly through this case. Same exact approach to treatment or doing the laterally closed tunnel. Single isolated tooth. We placed the harvest. We treated it like a Vista approach, but we closed the tunnel laterally. And you could see, as you could see, I left a portion of that graft exposed, right? And whatever the portion of the graft that was left exposed, which is this part, that's the new keratinized tissue, that area, whole area became keratinized tissue. So now you reestablish your mucogingival junction in the normal spot, and all of this is keratinized, beautiful root coverage, very stable tissue. Post-op, a lot of doctors ask me, what is your post-op? So generally, I don't remove sutures for FGG for about 2 weeks, and for any of the root coverage procedures, I keep sutures in for about 3 weeks. The brushing generally doesn't start until 3rd week, and it's generally using only on the teeth. You're brushing the teeth only. After 1 month, you can pretty much resume everything normal. Brushing, flossing, eating on that side, no restrictions. I always give antibiotics for anything that I place inside. I don't give antibiotics for free gingival grafts usually because it's an outside graft. And then I do use Paradex in these cases, starting usually at week 2, twice a day. And antibiotics, just very common. The last part I'm just going to go over just a few cases to finish up our lecture is just, talk about some of my bread and butter, which is aesthetic zone implants and aesthetic soft tissue grafting in some of these implant cases. Mostly, they're all mostly anterior cases. So we'll review a few of these, okay? So emergence profile is very important to understand. Whether you're doing a restorative dentistry or you're doing an implant temporization yourself. This is a great paper that's talking about critical, subcritical zone and how the contour should be more ideal to have these zones to be able to create volume of tissue around the implant. You don't want to have a tooth or emergence of a tooth to have the same emergence like a natural tooth, right? Implants don't work that way. So that critical zone, which is that small area right at the gingival zenith in the temporary face, should be under contoured by about 0.5 to 1 millimeter always to allow for some soft tissue creeping coronally, which you can mold and shape later on in your final stage or when you're ready for tissue training, but initially it should be short. Our goal is to either preserve emergence, right? If you have an immediate implant that was done, you either have to preserve that tissue so it doesn't collapse, or you have to create an emergence profile with a temporary, right? So it can be done either with a custom temporary, chair side or lab made, whatever you guys are comfortable with, or it could be done with a custom healing abutment. So immediate usually means we're supporting the tissue that exists, right? We want to prevent papilla to collapse, from collapsing. You want to prevent the gingival zenith from collapsing. And very important to know the critical zone. That's the zone that's immediately at the gingival zenith. In the temporary phase, it always has to be slightly shorter, so 0.5 millimeters shorter of the final temporary or the final position of the gingival zenith. You can also redevelop emergence profile after your implant was already placed. So let's say you could not, for whatever reason, you could not place the implant temporary at the time of implant placement. Let's say stability was poor, you placed the healing abutment only, like in this case, what happened was just very low torque. It was probably like 10 or 15 newtons torque. I placed the healing abutment. We let it heal. I think she healed for at least 2 or 3 months until implant got some initial stability. And then I came back and I started developing soft tissue contours. So this is the difference between this step and this step is only 4 weeks, right? So we moved from here to here in about 4 weeks. And I think this was 3 months after the implant was placed. So we waited like a month or 6 weeks. I started pushing tissue. 4 weeks later, we back to this beautiful, as you can see, papillas. This is the temporary tooth number 7. The papillas were nicely shaping up, similar to the contralateral tooth. This is still a temporary tooth, which in about a month later, we had her sent to a general dentist to restore to final. Okay, so preservation or redevelopment of an emergence profile, or called tissue training. Big aspect of soft tissue management around implants in the aesthetic zone. So this is the stuff that I love the most, I think, because I do a lot of these cases. But it takes time. You have to be very patient, and you have to make sure the patient is understanding of how patient you have to be, because it takes many appointments sometimes and a lot of time. In some cases, we have cases that are not ideal, right, from the beginning. Like this case, for example, what challenges do we have, right? We have pretty much no papilla on the gestalt. We have this weird, irregular gingival margin on the facial that, not very maybe pleasant if we were to put an implant there. So there's also kind of a deficiency in tissue thickness. Hard to see from this area, but from this view. But if you look from occlusal, it was a little bit deficient. And tissue was relatively thin. So in these cases, we do want to introduce some sort of autogenous graft, whether it's going to be a connective tissue graft or de-epithelialized version of a connective tissue graft, or tuberosity, right? In this case, I love the use of a tuberosity in the single use cases. You can place your implant. You could place your graft inside of the tissue to create a little bit more volume. Okay, this is how we grafted it, and you could make this patient temporary. So as you can see, the spacing here is a little bit weird because I think patient had originally a diastema right there on the distal aspect of the tooth, and he didn't want ortho. I mean, it would be ideal if we could bring this tooth a little bit more lingual to actually get this tooth to contact this tooth a little bit better, just close the gaps. But he didn't want to deal with it. So we said, okay, we'll just work with restorative a little bit later. So place the tissue graft internally right here, right? And this was just a mini vertical here. And the way I approached the incision design, I actually took some of the palatal tissue and I rolled that palatal tissue internally as well, right under the contour of the temporary restoration. Just rolled it under. And we let this heal for about 4 months. As you can see, what I didn't mention is that tuberosities, they tend to grow in thickness. So you start with, you think as you can see, kind of a mild contour here, right? Nothing too crazy, but then the patient comes back after 4 months, it actually grew in thickness. And that's could be a beauty and not beauty of using tuberosity grafts, but no problem in this case. Facially, patient cannot tell. I mean, it's beautiful that we were able to get so much thickness and protect the buccal of the implant. It just looks kind of crazy. That's the picture I want to show you. That's how much thickness you can gain with the tuberosity graft. And after that, we sent him to restorative to close the gap. The only way we could do this to improve the spacing is to maybe we prepped it for veneer, and the general dentist restored this case to final with just veneer as well as the final restoration. This is how we finished the case. So is it ideal in terms of the soft tissue? Well, it's a lot better than where we started, I think. Do you agree? The biggest challenge was to get this papilla to move even more coronally, right? I think we did push the papilla a little bit higher to this point somewhere, just a little bit higher, but it's not not as much as the contralateral tooth, as you could see, but still great outcome. I think patient was extremely happy. I used to wear this flipper for a while. He was a young lawyer, by the way. Just lost the tooth and finally was excited to get a final tooth that doesn't have to come in and out. So that's how we finished this case. So, and again, moral of the story there was basically if you have a deficiency, nothing comes close to better outcome than using some soft tissue grafting in this kind of cases. So what about this one? Should we attempt the root coverage or not? So before I saw this periapical X-ray, actually, I was very excited to attempt some laterally sliding pedicle graft, and I'll be this rock star that covered this massive root, right? And then I saw this this X-ray which made me kind of rethink my strategy. And this was a failure of endodontic. Surgical endodontics. So they attempted to do an apicoectomy, which gone kind of south, developed into this massive recession over time. And she's relatively well off, kind of good looking lady. She's an artist in Santa Monica, and she just didn't care for it for too long. I mean, it was like 10 years she was like that. So she finally decided to do something about it. In these cases, you absolutely must already involve soft tissue grafting as well as the bone grafting, right? So as you can see, it's healthy. There's not much infection going on in there, but what I usually do when I'm deficient in the soft tissue, I cannot do my grafting at the time of extraction. I just extract the tooth and let the body mature the tissue. It's going to fill in within 2 months. After 2 months of maturation, as you can see, it's completely back to great coverage, great soft tissue. We are absolutely deficient in bone and thickness of tissue, but we have good coverage for whatever plan is next, right? And our plan here is to do an augmentation procedure, which is what we decided to do, a sausage approach ridge augmentation. I think I used autogenous here, autogenous allograft combination, and we tacked, again, this is a Renedix Plus, one of my favorite membrane for tacking from Salvin. This is the top picture showing autogenous that was scraped straight from this nasal spine here. And this is a mixture of allograft and it's a cortical cancellous allograft, about 70% and 30% just cortical allograft, just to get more stability a little bit long-term to decrease the resorption time. And the rest is autogenous. 6 months had passed. We took a CT scan. The CT scan had a phenomenal bone on the CT scan, so we made a small papilla-sparing flap, just bring the palatal tissue. As you can see, I made my incision very palatal, so I can roll that palatal crestal tissue onto itself and under the contour of the temporary restoration, which we did immediately. This is a subepithelial graft that we harvested and virtually did the same thing as I did on the previous case. I placed the graft inside here, and then we sutured everything sort of coronally, and the graft is internal from here to here, right? It's right underneath this flap, and this area is very concave, right? There's all the space for my connective tissue to grow, for my flap to attach to that connective tissue. Immediate temporary is very, very important. And pay attention to where the papillas are in this case at this point where it is now, and how we went through a little bit of maturation time. So this is just 3-week follow-up. As you can see, beautiful healing, massive gain in thickness overall, massive gain in, there's basically that tumor looking thing from the bone graft that we did, but also a quality tissue that was gained by the use of a soft tissue graft. And this is a 4-month follow-up. Great fill in the papilla. I mean, I could not ask for the midline papilla to migrate even higher, because this looks exactly, I might show you the before and after, is in the same spot as we had before the tooth was extracted, I think. So we got pretty close to it, even though we had to jump through so many hurdles. But look at the gain and keratinized tissue here and the thickness of that keratinized tissue here, right? So nothing can beat this. Basically, we've done everything possible to give this implant a chance to succeed for many years. And I always make referral doctor a custom impression coping. As you can see, this is a custom impression coping to be able to translate the information I've made with my temporary to lab, so the lab can fabricate this identical emergence profile for the final restoration. And this is sort of how we turn between the pre-op. As you can see, the papilla, midline papilla, virtually in the same spot as we started with, almost maybe almost identical in that sense. Distal papilla, kind of a similar, a little bit less less height here, but with the challenges we have to jump through, I think this is a fairly good outcome. So I think I don't know, Ellie, how much time do we have for the lecture?
Actually, it was only 1 hour, but
1 hour.
But if other doctors wanted to go for more, then should be okay. Do you have more slides left?
I have like maybe a few more slides left, maybe 2 more cases if you want me to show a few more of these cases in the anterior aesthetics. But if doctors have questions, we can just wrap it up here. It depends.
Is anybody okay to go for further with the more slide? I guess yes, yeah. Because their time is kind of what I think it's 9 o'clock over there.
Okay, well, I'll just show. Let's see what case I had here to show. Let me see. Let me just show this case and we'll wrap it up. So sometimes there's challenges like this. So this is a challenging case in the sense that there are number one, this is an old implant, right? Number 9 is an implant. There is a large recession with severe bone loss, and there is a bone deficiency to be able to consider implants in this area. So we have to manage both the implant placement. We have to graft this area. This was a mixture of an allograft and autogenous tissue. But at the same time, as you can see, I took some of that connective tissue just from that local area right next to it, and we're able to secure that connective tissue graft onto the root. And what we're hoping here is we're hoping to bring this tissue, the mesial tissue, because we have the thickness of the connective tissue that's going to wrap around this, to bring the tissue more coronally and hopefully get some root coverage on this tooth and maybe stabilize the overall tissue height across the tooth. So the way we did this is we created this surgical papilla right here. As you can see, my incision design, I went across the papilla, and this portion that I split is becoming the new clinical papilla, because this new clinical papilla is going to go coronal and lay on top of this area, which I'm going to deepithelialize. Deepithelialize, what I mean by that is remove this epithelium, right? So that new papilla gets coronally positioned here, and it gets secured more coronally, right? So here's another view. So this is the papilla that we've created. We coronally positioned, we advanced the flap, everything was advanced coronally, and this graft was sort of wrapped around to give some volume and attachment on the mesial aspect of the tooth. And this is how we're looking at 4 weeks. I think he's actually coming in for 6-month follow-up already, and the tissue's been hanging in here, phenomenally all the way at the top. So again, the moral of the story, nothing comes close to autogenous connective tissue grafting. If you have defects like a recession defect or any deficiency in soft tissue and bone, definitely consider using connective tissue grafting, just like in this case. You can also consider using a tuberosity graft in these type of cases as well to, to create more volume if you need to. He will get another connective tissue graft when we're going to expose this area to create more volume in the actual area right here. So we're going to probably take another deepithelialized graft and insert that into this area at the time when we're doing a stage 2. Any questions, Ellie? I think I'll just tap out right here because it's getting late for them.
Okay, sounds great. If anybody has any questions, you can unmute yourself and feel free to ask any questions. We have about like 5 more minutes to go.
Yeah, and if anyone has questions, they can always reach me through, if you just follow me on Instagram or find me on Facebook. I can always answer any of these questions. I can share any of the articles that I mentioned in my presentation as well. I think they're all either passed out to sleep or they're just too tired.
Yeah, probably.
Probably.
Okay, so is everybody okay to wrap it up? Okay, I guess yes.
All right. Well, thanks for having me. It was always it was fun as always.
All right. Thank you so much.
Thanks, guys. You have a great night.